Hello medicos, welcome back to my channel, and today let me present to you the Pediatrics Sunday. So what's special about this Pediatrics Sunday? Yes, today we'll be discussing about the fetal circulation. Okay, so about the fetal circulation, you need to know that during the fetal life, the lungs are not functioning. So the placenta is required for the exchange of gases and the nutrients. So these umbilical vessels, that is one umbilical vein and two umbilical arteries, are basically doing this work. So the umbilical vein will be carrying the oxygenated blood, while the umbilical artery will be carrying the deoxygenated blood. Now this umbilical vein, as you can see here, will be traveling and will be passing to the inferior vena cava. Umbilical vein again will be passing to the inferior vena cava via this shunt. This shunt is called as the ductus venosus. So as you can see here, the shunt here is called as ductus venosus. After this, through the inferior vena cava, the blood will reach the right atrium. And in the right atrium, 2/3 of the blood will enter the right ventricle, while 1/3 of the blood will enter the left atrium. This 1/3 of the blood that enters the left atrium is via this yellow colored foramen that you can see here, called as the foramen ovale. Okay, and the blood that reached the right ventricle, that via the pulmonary trunk, will basically should go to the lungs. But since lungs are not functioning in the intrauterine life, therefore this blood from the pulmonary trunk will shunt to the aorta, as you can see. So this shunting of the blood from the pulmonary trunk to the aorta is via this yellow colored shunt called as the ductus arteriosus. Let me just quickly revise again. The blood from the umbilical vein, the oxygenated blood, it bypasses the inferior vena cava via this shunt, that is ductus venosus. From the inferior vena cava, blood reaches the right atrium, which reaches the right ventricle, 2/3 of the blood, and 1/3 reaches the left atrium. The blood that reaches the right ventricle will now enter the pulmonary trunk, which will bypass to the aorta via this shunt called as the ductus arteriosus. Now what happens after birth? The placenta is cut off, the umbilical vein blood will be seized off. Okay, so there will be closure of this ductus venosus. Also, the baby will breathe, okay, and the oxygen will henceforth enter the lungs. So this entering of the oxygen into the lungs is the strongest factor for the closure of this ductus arteriosus. Also, since the air has reached the lungs, that will cause decrease in the pulmonary artery pressure, decrease in the right chamber pressure. Since the umbilical vein is clamped, there will be increase in the systemic vascular resistance, that will increase your aortic pressure and will increase the pressure in the left chamber of the heart. And that is what actually happens. Your left chamber of the heart has higher pressure than your right chamber of the heart. I hope you guys have already understood what I am trying to tell you. Now let's understand what is the time of closure of these shunts. Okay, so basically one is what we call as the functional closure, another is what we call as the structural closure. Okay, so the umbilical vessels, the ductus venosus and the foramen ovale, they close as soon as after birth. Soon after birth, they'll close. But the ductus arteriosus, it will close 10 to 14 hours after. 10 to 14 hours after birth. Okay. On the other hand, if I talk about the anatomical closure, then the umbilical vessels, they will close by 5 to 10 days anatomically. The ductus venosus will close by 3 to 7 days anatomically. The foramen ovale will close by 3 months after birth and may also take some years to close. And ductus arteriosus will close by 10 to 21 days after birth. Henceforth, what do we interpret? That the last structure to close anatomically is foramen ovale, that is by 3 months. But the last structure to close functionally is ductus arteriosus, that is 10 to 14 hours after birth. I hope you are clear. Now let's discuss about certain congenital anomalies and the related heart defects. Okay. So, in Down syndrome, a child can have a heart defect that we call as the endocardial cushion defect. The endocardial cushion defect. In Turner syndrome, the child will have bicuspid aortic valve more than the coarctation of aorta. Can have both, but the chances of bicuspid aortic valve is higher. In Noonan syndrome, they have pulmonary stenosis. They can also have ASD, that is atrial septal defect, and hypertrophic obstructive cardiomyopathy. In Dijot syndrome, also known as the catch-22, they have conotruncal anomalies. Okay, now what if the mother is exposed to certain factors during her pregnancy, like the mother has overt diabetes? So the child has chances of having ventricular septal defect most commonly. For congenital rubella syndrome, the child has chances of having patent ductus arteriosus, can also have pulmonary stenosis, and can also have ventricular septal defect. Okay. In case of lupus, the child can have congenital heart blocks. In alcohol syndrome and phenytoin syndrome, the child can have ventricular septal defect. And very important, in case of lithium exposure, the child can have Epstein's anomaly. I hope you understood all these conditions and the related heart defects. Now let's move on to the very important NADA's criteria. So this NADA's criteria is used to assess for congenital heart diseases. So we have major criterias and we have the minor criterias. There are 4 major criterias and we have 5 minor criterias. Systolic murmur of more than equal to grade 3, a diastolic murmur of any grade, the presence of central cyanosis, and the presence of congestive heart failure. These are the 4 major criterias. The presence of systolic murmur but of less than grade 3, abnormal second heart sound, chest x-ray, blood pressure, and ECG, they come under the minor criteria. So when to suspect congenital heart disease? When we have 1 major plus 2 minor, then we can suspect congenital heart disease. I hope this class was helpful and you could revise the topic quite well. We can also discuss each congenital heart defect individually in our further videos, but I need to make sure that you really want to listen to them. So for that, you need to comment down in the comment section. Don't forget to follow my channel and subscribe to the channel for more such videos. Thank you.